morning. Please take a moment and silence all pagers and cell phones. Today we have the pleasure of hosting Dr. Ari Grinspan for a talk on fecal microbiota transplantation. Dr. Grinspan is an associate professor of medicine at the Icahn School of Medicine at Mount Sinai. He received his Bachelor of Arts from the University of Pennsylvania and received his medical degree from the Albert Einstein College of Medicine, where he was inducted into the Alpha Omega Alpha Honor Society. He performed his internal medicine training at New York Presbyterian Hospital, where he served as assistant chief resident. He completed his gastroenterology fellowship here at Mount Sinai, where he served as chief fellow. Dr. Grinspan pioneered the Fecal Microbiota Transplant program to treat recurrent and refractory Clostridium difficile infection at Mount Sinai, which he has now developed into a leading referral center in the tri-state area. His research focus is on exploring the mechanism and clinical utility of fecal microbiota transplantation in Clostridium difficile infection and inflammatory bowel disease. Please help me in welcoming Dr. Ari Grinspan.
First, I'd like to thank Professor Murphy for promoting me so early in my career. I appreciate that. So I will be giving a talk about FMT. No, thank you. Fecal Microbiota Transplantation, which we use for C. diff. And I'll talk mostly about C. diff just because I think that it's more apt for this audience, but I'll also talk about indications or possible indications beyond C. diff. So I actually have a disclosure. I will be a site investigator for a clinical trial involving Seres Health, which I'll talk a little bit about later in the talk. FMT, Fecal Microbiota Transplant. You can't turn on the news, you can't go on to Paris Hilton without finding something about FMT. There are multiple blogs out there, The Power of Poop, Poop Power. There's multiple YouTube videos about how you can actually do this at home. We call it the DIY or do it yourself. I do not recommend that. And I think the heyday came in December and actually recently in May when the New Yorker published an article called The Excrement Experiment, which sort of highlighted what I am trying to do here. And then actually, unbeknownst to me, I found myself in Esquire magazine in May talking about what the services that I provide. So the joke in the division is that I actually published in the most prestigious journals. So this is the outline of my talk. I'll talk briefly about the introduction to the microbiome. There's some terms that you just sort of need to be familiar with before I go along. Then I'll talk about C. diff. Then I'll talk about the use of fecal transplant for C. diff, and then use in other indications. So first, some definitions. The microbiome. What is this microbiome we keep hearing about? It is the ecological community of commensal, symbiotic, and pathogenic microorganisms that share our body space. The microbiota, or when I refer to the microbiota, I will be referring to the actual bacteria that reside in our gut. The microbiome is actually how the bacteria interact with us. And then I'll be mentioning this term dysbiosis. The dysbiosis is what I will refer to as a disruption in the gut bacteria that typically lead to disease. So in our guts, or in our bodies, there are 10 times as many bacterial cells as there are human cells. So we're actually more bacteria than we are human. If you talk to the geneticists, they'll say it's actually more staggering than that. There's 100 times as many bacterial DNA as there is human DNA. And for the first time, we're actually able to study the microbiota via culture-independent pathways. So what we used to do is we would take a swab, we'd grow it up, and whatever grew, we would decide, well, that's what's in our guts. Well, it's far more diverse and than what we expected. What's interesting is that in our colons, there's only about 150 species. Now, each one of us has our own, if you would call, fingerprint of what our microbiota and microbiome is made of. And this is finalized by the age of about 2 or 3 years old, and it's influenced dramatically by the mode in which you were delivered, C-section or vaginal delivery, and your environmental exposures. Did you live in the city? Did you live in the suburbs? Did you travel to Maine in the summers? Were you given antibiotics for an ear infection at a young age? what we find is that it's dominated by two phyla, Bacteroidetes and Firmicutes. I'm not sure if it's called Firmicutes or Firmicutes, but Larry Brandt up in Montefiore says it's Firmicutes, so it's Firmicutes. Now we'll talk about C. diff. So, as all house staff know, you see C. diff everywhere, and it's been on a significant rise over the past decade. So if you look specifically in the older population, so in this over 85-year group, and the 65 to 84, you can see a dramatic increase in C. diff over the past couple of years. So what are the typical risk factors for developing C. diff? Well, we all know antibiotic use, hospitalization or healthcare exposure, living in a nursing home facility or long care facility, elderly patients, which I just showed you, and a couple interesting things you just need to be aware of. PPI use. There's a twofold increase in C. diff if you are on a PPI or not on a PPI. Patients with IBD frequently come in with a flare. The first thing we need to check as soon as they hit the emergency room is make sure that C. diff is not playing a factor. Pregnancy. Increased rates of C. diff in pregnant patients and anybody who is immunocompromised. What's interesting is that when you think about C. diff, you always, at least I always think about an elderly patient in the hospital with a UTI or pneumonia. They get their 5 days of antibiotics, then they develop diarrhea. Sure enough, they get C. diff. This just came out in New England Journal. This was a cross-sectional study of multiple centers across the United States looking at rates of C. diff. What they found is that there's about close to 500,000 incident infections of C. diff in the year 2011. 500,000. Half of those, just about half, were acquired in the community. So this is a changing manifestation of what we're seeing with C. diff. We're used to seeing it in the hospital, but now it's actually a lot more of it is coming from the outpatient world. And what's interesting, about 500,000 patients, 30,000 of those died within 30 days of a diagnosis of C. diff, and half of those, or 15,000, were died directly from their C. diff. So this is a bad bug, and it's costly. This is numbers from 2010. I think this is a gross underestimation. $1 to $1.6 billion a year. Other estimates, and this is just including acute care facilities. This doesn't include the outpatient world. It doesn't include long-term care facilities. If you include those, it's closer to $4 billion in 2010 was spent directly for treating C. diff and its complications. I found this last night. I thought it was interesting. This is coming from Virginia. In the VA in Virginia, the average cost of a hospitalization is about $8,800. When you have C. diff, it's $23,000 for the same hospitalization. So it's a dramatic increase in cost. The American College of Gastroenterology has come up with sort of a rubric for monitoring severity of disease of C. diff. They separate into mild or moderate, severe and complicated. Mild to moderate is basically they just have diarrhea without any of these things below. Severe C. diff is considered when you have an albumin less than 3 and one of the following two things. Either a white blood cell count greater than 15,000 or abdominal tenderness. One of those two satisfies, and then boom, you get severe C. diff. Then when you have severe and complicated, any one of these things counts towards that category. So being in ICU, having sepsis, having abdominal distension or ileus, or any end organ failure. So how do we treat C. diff? What's our current guidelines? So for mild to moderate, metronidazole or vancomycin. For severe patients, go right to vancomycin. For severe and complicated, combining vancomycin with IV metronidazole and using vancomycin enemas for patients with ileus. And then this is the current guidelines for recurrent disease. So on the first episode of recurrence, use the same regimen you used previously. Your second recurrence, they recommend a pulsed vancomycin regimen, which is typically, everyone sort of does this differently, and it causes trouble for patients because it's difficult to follow. But typically, it's 2 weeks or 10 days of vancomycin 4 times a day, and either tapering that down by 1 pill a day over the course of 2 or 3 weeks or 4 weeks, or by giving a pulse regimen. But pulse means is you give them 4 pills a day, then 3 pills a day, then 2 pills a day, and then you have a day off, and you go back to that 4 pill a day regimen. These numbers are pretty staggering. 20% of patients will have a recurrent episode after the first treatment. 40% will recur after a second treatment, and 65% of patients will recur. That's more than half of patients, if they have were treated for a third time, will have a fourth episode of C. diff. These numbers are pretty outstanding. Great for business, but outstanding. Okay, why do these patients with recurrent C. diff have recurrent C. diff? What is it about them? So we first looked at their microbiome. We looked at the bacteria, what's been happening with these patients. The green and red bars are the healthy Bacteroides and Firmicutes. And so if you look at the control population, you can see if you look at their bacteria, they have these big swabs of green and red. This is healthy. Even after the first episode of C. diff, once they clear the infection, they continue to have healthy-looking microbiome. It's when you look at the patients who had their second, third, fourth recurrence that you see these dramatic changes. You lose the green and red. You get to see these other bacteria that are typically in the minority that sort of become the majority, proteobacteria and others. And you can see this on this chart very nicely. This is diversity. You can see that the controls, and even in the index population, they have nice, diverse bowel microbiota. But in terms of the recurrent C. diff, they just can't quite get up to that normal diversity, which is what we think leads to this increased rate of recurrent episodes. So briefly, we'll talk about where fecal transplant comes from and where it has a role today. So in 400 AD, or about that time, Gi Hong reported the first use of a fecal suspension, which they would give orally to patients in China that would treat nausea, vomiting, I thought that was interesting, abdominal pain, distension, constipation, and diarrhea. The translation turns to yellow soup. So what I learned from this is when I go to a Chinese restaurant, I never order yellow soup. In 1958, Ben Eisman, who was a chief of surgery out in Denver, had 4 patients who had pseudomembranous colitis. And this is what he saw. This is what he saw in their colons. He didn't know what it was. He didn't know this was C. diff. He looked in the literature to find out why this was happening to the patients, and he found that in the veterinary literature, this happens all the time. And veterinarians treat their animals with stool from other healthy animals. So we took the spouses of these 4 patients, took their stool, made a slurry, and gave them retention enemas, and cured the 4 patients who had this pseudomembranous colitis. Made a small splash in 1958, and then no one really made any advances after that until 1983, when the first case of C. diff was actually treated with a fecal transplant in Scandinavia. Shortly after, Larry Brandt up at Montefiore and Thomas Brody in Australia sort of made this more and more popular. 2013, I performed the first fecal transplant here at Mount Sinai under the tutelage of my mentor, Ashisha Treja. This is what a normal colon looks like. You can see the nice vascular pattern. It's pink, it's pretty, it's beautiful. This is severe pseudomembranous colitis. And I'm going to show you what I actually do. So during a colonoscopy, the movement is just her breathing. And you'll see the money shot. There it is. You've all witnessed a fecal transplant. Congratulations. That's it. That's all that I do. And it is dramatic, the amount of effect that I get from just putting in some regular old stool into the colon. This is the same patient 1 month later. And I apologize. I know you guys have your coffee and everything, but I showed this picture for one very important reason. This is a solid piece of stool. This is the first time in 3 months that she had a solid piece of stool. She called me complaining about constipation. I said, don't worry about it, you're going to be okay. There is still a little bit of remnant erythema, but you can see normal vascular pattern, and otherwise she did remarkably well. So, how does this work? What did I do to her? We don't really know, to be perfectly honest. There are a lot of theories about what we're actually doing by placing stool into somebody's colon with C. diff. And these are the sort of the 4 leading hypotheses. It's probably not just one, it's probably all of them combined. But real estate. So C. diff has to take hold in the colon in order for it to be able to produce toxin. It just can't just sit around. It has to be attached to the colonic mucosa. So are we getting rid of that by overwhelming the colon with all these other bacteria that will then compete for real estate, kind of like living in Manhattan? Are we just, by overwhelming the colon with bacteria, are we out-competing C. diff for nutrients? Are we giving bacteria that produce local antimicrobials that kill the C. diff for us? Maybe. The other thing that's interesting is that if you look at patients with C. diff and you measure their bile acids, it's almost all primary bile acids, and C. diff grows very well in that milieu. Once you add secondary bile acids, they do not grow very well. So potentially by introducing normal, healthy colonic bacteria, which normally conjugate to secondary bile acids, we are diminishing the ability for C. diff to grow. Possible. You can't talk like that to your patients when you're talking about fecal transplant because they just don't quite grasp it. So this is what I tell them. Imagine a healthy lawn where every blade of grass is a healthy microbe. Something happens, usually antibiotics, and you get weeds or C. diff. You can throw all the weed killer you want at the weeds, metronidazole, vancomycin, but the weeds continue to come back. So sometimes what you need to do is re-sod the soil. If you re-sod the soil, you get back your beautiful, healthy lawn and go out and have a barbecue. Patients love that. So what are we actually doing by giving a fecal transplant? So this is a study done a couple years ago, looking at a patient with C. diff and looking at their microbiome. This is the patient's donor. You can see this big swab of orange. This is Bacteroides, healthy, normal bacteria. 7 days after transplant, here's the patient. He looks remarkably similar to the donor, C. diff negative, having normal stool. If you follow this patient for 30 days, for a month, this is what the patient now looks like. C. diff is negative, but clearly different than what his donor was. What we do not know is this the patient's new normal, or is this what the patient looked like sometime before he had C. diff? We have no idea. What we do know is this patient is healthy and everything is fine and C. diff is negative, so we consider that a success. So in January 2013, the New England Journal published the first randomized control trial of fecal transplant for C. diff. This was done in the Netherlands. They split their patients up into 3 groups. There was an FMT arm, a vancomycin arm, and a vancomycin plus bowel lavage. Now look at these numbers. These numbers are very, very small, 16, 12, 13. But this study was stopped early because of this dramatic effect. So after the first donor infusion, and this is the Netherlands, they have to cut prices. This was done by a nasodudunal tube. I do not recommend that you do that for your patients. They found 81% of patients after one single infusion were cured with no diarrhea, C. diff negative at 10 weeks. Look at the vancomycin group and the vancomycin with bowel lavage. 30% and 23% cure at 10 weeks. Dramatic results. This is the patients who failed their initial transplant and got a second one. So after 2, it went up to 94%. I feel like a surgeon with some of the numbers that I'm getting. It's pretty outstanding. This was just published last month in APT. Another randomized control trial, this time using FMT via colonoscopy compared to vancomycin. Again, these are patients with recurrent episodes of C. diff, coming in with a recurrent episode. The FMT group got pre-treated with vancomycin, which is sort of, in the FMT world, we like the idea of pre-treating the bowel because we want it to be raised. We want there to be no microbes left when we give this new healthy bacteria. That's at least the thought process. So we're pre-treated with 3 days of vancomycin, given a bowel cleanse, and then given a fecal transplant. The vancomycin group had the standard vancomycin therapy, 10 days of vancomycin followed by a pulse regimen for 3 weeks. These are the results. Very similar to what you saw in the publication we just showed you. 90% of patients had, at 10 weeks, were diarrhea-free and C. diff negative, compared to only 26% in the vancomycin group. Pretty outstanding numbers. If you look across the board, this is about 500 cases altogether. There's about a 92% success rate across the board. Now, the majority of these are case series or case reports. However, a total of about 500 cases, so still it's a dramatic improvement. Now, I don't know if you caught this, but the two studies were different. One was given via the upper GI route, the other was given via colonoscopy. Well, is there a difference between the two? And it appears that there is. It appears that if you give it via the upper GI route, you only get about an 80% success rate, efficacy rate. However, you give it via lower GI route, via colonoscopy, there's a 93% cure rate. So both very, very good, but it looks like using the lower GI route seems to be a bit better. Begs the question, why are we even giving antibiotics? Why shouldn't we just move directly towards fecal transplant? As I mentioned to you earlier, this is almost a $4 billion problem that we have. So these are just estimates that we put together for one of the GI conferences 2 years ago. At that time, fidaxomicin for a 10-day course was $3,500. A vancomycin taper, $1,800. Vanco with a rifaximin chaser, which is basically 2 weeks of Vanco and then rifaximin for 2 weeks afterwards, $2,300. FMT via colonoscopy, $1,600. FlexSig, $1,100. NG2, $1,400. So just by seeing that, you can tell, well, why are we even doing this? When you make a decision analysis based on the numbers, the efficacy rates of FMT versus Vanco versus flat metronidazole versus fidaxomicin or Difacid, what you see is that after a first recurrence, FMT is the most cost-effective strategy as long as your cure rates are above 82%. I just showed you that across the board we have over 90% efficacy with FMT. For a second recurrence, as long as FMT is more than 50%, it's cost-effective. So our data suggests that FMT appears to be the most cost-effective strategy for recurrent FMT, period. And this was confirmed in a recent study that was published in CID. This sort of is a summary of information I've already told you, but in a different way. This is one patient. If they got antibiotics, there's an 80% chance of cure. If they recur, they get antibiotics again, there's a 60% chance of cure. If they recur and they get antibiotics a third time, it's a 35% chance of cure. But if they get FMT at any point in time, and again, a couple years ago, the only time we were using FMT was in this really refractory recurrent group, you get 92%. And so what they came up with in their analysis was that it indicates that a strategy comprised of initial treatment with FMT, initial treatment, that doesn't say give them another course of Vanco, initial treatment of recurrent C. diff is the most cost-effective for management of recurrent C. diff. FDA. May 2013, the FDA decided that they're going to put the kibosh on FMT. We're not going to let you do it because stool is a drug. So I'm looking at a lot of drug pushers out there right now. And what we called the brown market became a little crazy. There was the outpour of support for FMT among patients and doctors was incredible, where that 2 months later in July, the FDA reversed their decision and said, okay, you can use it, but only for C. diff, and we're going to use something called enforcement discretion, meaning just make sure you know what you're doing. That's basically what they mean. So their big concern was, we're using this product, but is it safe? We know it works, but no one's reporting anything bad in the literature. This is what is in the literature. A couple of fevers that happened in the first 24 hours that self-resolve. An episode of rotavirus and norovirus. This was in Seattle. An aspiration pneumonia when it was done via nasogastric tube. This was in Europe. Ibd Flare, which I'll talk in a moment. And one case of obesity. This was a mother-daughter pair. The mother had C. diff. The daughter had a BMI of 31 at the time of fecal transplant. Gave the stool to the mother, cured her of C. diff. Over the next 6 months, she continued to gain weight, and they didn't understand why. She gained 40 pounds in the following year. And now her BMI was 31 as well. Now, there's a lot of things that could be contributing to that. But because of this, we changed our policy. We do not use donors who have a BMI greater than 25. You have to be between that 18 and 25 mark. Otherwise, you're out. There's still this risk of transmitting infection. Think about blood donation back in the 70s and 80s. We were transmitting hepatitis C and HIV. We didn't even know these things could be passed via blood. We didn't know that they existed. So is it possible that we're transmitting something that we don't even know exists yet? Yes, it's possible. There's also theoretical risks, which I'll talk about in a moment. The microbiome has been associated with so many different disease states, whether it's autism, whether it's cardiovascular disease, obesity, diabetes, IBS, colon cancer. Are we going to be transmitting the risk of these certain things from a patient, from a donor's microbiome, and give that susceptibility to the patient? That's never been shown, but it's something that we have to talk about. So this is the Ibd Flare. Colleen Kelly up at Brown had a 78-year-old man with quiescent UC, had UC for 20 plus years, has been off all medications, was doing very well. He had relapsing C. diff after he was treating for a pneumonia. His wife was a donor. This is his colon, normal vascular pattern. These little things right here are called pseudopolyps. These are evidence of his prior disease, but no active inflammation. 9 days later, he comes to the emergency room with an ulcerative colitis flare, his first in 20 plus years. As you can see, it's granular, it's erythematous. He did well with steroids, but this is a cautionary tale. There's been one other report in the literature that shows this, but that's really it. It's only been those 2 reports. However, it's something that we have to consider. This is another patient of Colleen's who had IBS. She had recurrent C. diff. This is her colon. This is disease from the C. diff. This is a biopsy. 6 weeks after her transplant, she has severe diarrhea and with some blood. On her colonoscopy, she has an ulcer now. She's never had an ulcer. She had irritable bowel syndrome. She didn't have inflammatory bowel disease, or so we thought. This is her biopsy, and you can see there's a tremendous inflammatory infiltrate here. So again, a cautionary tale. This is a retrospective study of 66 patients who were immunocompromised, who received a fecal transplant for recurrent or refractory C. diff. Of the 66 patients, many of them, about half of them had IBD. A quarter of them had a solid organ transplant, liver or kidney. And there were still very good success rates after a fecal transplant. And importantly, there was 0 infectious complications in this group. Again, it's a retrospective study, but this gave people a little bit more, it helped people sort of with this more difficult population. So here's my protocol. This is a protocol that's in evolution. This is when I started in July of 2013, and I've become much more aggressive with how I'm using fecal transplant. But at least 3 episodes of mild to moderate disease, or if you're not responding to vancomycin after about a week, or if you are severe and you're not responding to standard therapy within about 2 days, I'll consider performing a fecal transplant. I screen the donors, I screen the patients. If you have decompensated liver cirrhosis, if you had advanced HIV/AIDS, if you have a history of bone marrow transplantation or other severe immunodeficiency syndrome, I will have a conversation with you and your primary team about this. I get some baseline blood tests just to make sure I'm not going to be conferring anything to the patient that they didn't already have. And then I screen the donor. Now, I used to do all of this myself, and I'll tell you where I've sort of moved to make things a lot easier and streamline this whole process. But donor screening is basically like you're giving blood. You answer all of those questions, and then you have a very specific GI questionnaire where we ask you anything and everything that could be related to the GI health. Ever have an ulcer? Ever have H. pylori? Ever have colon cancer? Ever have a polyp? You are excluded as a donor. This is my protocol. The donor, if they qualified, would provide me a fresh donation on the day of the procedure. I would take 40 to 100 grams, or a couple of spoonfuls, and I would dilute it in 500 cc's of normal saline, filter, draw into 60 cc syringes, and infuse at the time of colonoscopy via the biopsy port. I infuse it at the most proximal extent of the exam, and then I literally rip the scope out. I don't want any of that stuff following the scope out of the patient. I give them Imodium immediately after the procedure, and I tell them to hold it for 4 hours. Most people don't have a problem. It's the ulcerative colitis patients that are not able to do this, but that is actually okay. I prefer to mix my stool. I'm a James Bond guy. I'm sorry. But I'm not doing this anymore. I'm an attending now. What can Brown do for you? These are individual frozen samples that are produced, produced I should say, in Boston from a company called Biome. It's a non-for-profit. They do this because they're a bunch of MIT guys whose best friend had cancer, had recurrent C-Diff, and they read about this incredible treatment opportunity, and nobody was willing to give it to him. So they did it themselves, and they cured him. He is now the COO of the company. The joke among Biome is that it is harder to become a stool donor than it is to get into MIT. Less than 10%, so they're across from Harvard. They put out this ad for $50, just give us a sample and we'll see. So they get a massive amount of people who come in, and over 90% of them are excluded. They then do tremendous screening, more than I actually did when I was doing my own screening. And then they screen them again once it's frozen, just to make sure in the next 6 weeks that nothing has happened to that patient. If something happens, that sample is thrown out. But then literally, they FedEx this to me overnight, and I can give it to a patient the following day. It's tremendous. So here are my results. I've completed FMT on 68 patients to date since July of 2013. The vast majority of these have been in the past 12 months. I've been averaging about 2 a week or so. This includes all patients that I have an 8-week, or actually a 10-week follow-up on. I have a 95% cure rate for C. diff using fecal transplant. The vast majority of these patients have had 4, 5, 6, 7 episodes of C. diff. It's really outstanding. When you separate it, IBD versus non-IBD, I still have 95% success rate. Now, there's a caveat. Some of these patients require more than 1 transplant. Some of these patients will feel great for about 4 or 5 days afterwards, and then all of a sudden their diarrhea will recur. So I give it to them again, and they do great. What's interesting, and this is across the board, so Thomas Barodi in Australia has done over 5,000 of these, and about 3,500 of his patients are women. Unclear exactly why that is, but I see the same thing. The majority of my patients are women. An average number of FMT, it's similar across the board. So I've done 3 pediatric cases so far with Keith Bankov and Marla Dubinsky. I did a patient with NG tube who was, I don't prefer to do that, but she was very sick and she had Crohn's colitis, so I gave her the NG tube. I did a patient who had, for 3 years, was living in a home. He's got severe MR. He had his stomach was removed from a massive gist about 10 years ago. And for the past 10 years, he's had C. diff. He's been living in isolation in a nursing home for 10 years on vancomycin suppression therapy, 1 to 2 pills a day. Every year, on his birthday, they stop the vancomycin and see how he does. Every year, 2 weeks later, he gets C. diff again for 10 years. He was referred to me. He had a PEG tube for feeding. I gave him 60 cc's of FMT via his PEG, and he's been C. diff free now for about 12 months. Absolutely incredible. I did not include that I've done several liver transplant patients and 2 kidney transplant patients, both who did remarkably well. Now, I've had some failures. 3. I've had 3 failures. One of them received antibiotics post-transplant on day 2 because he developed a phlebitis in his arm where his IV was. He was given antibiotics, and 5 days later his diarrhea returned. I gave him another transplant off of antibiotics, and he's done remarkably well. 2 patients with severe C. diff who had pseudomembranous colitis at the time of initial colonoscopy, they failed, but I think I know why. We talk about the severity of C. diff, the severe and complicated group. There's been special interest in this group because fecal transplant is so remarkably effective. And normally, if these patients go on and on, they go on to colectomy, and they do not do well with colectomy. There's like a 50% mortality rate if you have to go for to get your colon removed. So this is a protocol that was put in place by Monica Fisher out in Indiana, when she shared it with a bunch of us who were doing fecal transplant. In the severe complicated group, you give them vancomycin for 5 days. You do a colonoscopy or a flex sig. If there are pseudomembranes present or not, regardless, you give them the fecal transplant. But if it is present, you restart the vancomycin the following day for 5 days, and you see how they do. If they do well, great. You finish out your 10-day course, and you see them in the outpatient world. If they continue to be symptomatic, you repeat the above. So this is what we call response-guided FMT. So of her, this is what she just emailed me the other day. She's done 33 patients so far with severe C. diff. 20 of them are considered to be the severe and complicated group. They were all in the ICU, all for 20 patients. 4 out of those 20 patients failed and actually went on to die. But 16 of those patients walked out with their colons. She has a total of about 88% cure rate, 12% failure. But again, in the severe and complicated group, about 20% of those patients failed. This is what I've done. I've done 11 patients who've been classified as severe and complicated C. diff. 7 of them had pseudomembranous colitis at the time of initial colonoscopy. 5 were done in an ICU setting. I've cured 82% of them. They walked out with their colons. The other 2 actually walked out, but just were on vancomycin. The 2 failures had pseudomembranous colitis, but I didn't know that this existed, and so I only gave them 1. Is it possible that if I gave them another, if I followed this protocol, that I could have cured those 2 other patients? I like to think so, but clearly who knows. But I've had a very successful run with curing this very, very sick population. So I have a proposed algorithm. I think for the mild to moderate, absolutely, give them a course of antibiotics. Once you get severe and you're not doing well for a couple of days, consider using a fecal transplant. Severe and complicated, I think 3 days might be even a little bit too much. Let's give them 48 hours and see how they do on standard vancomycin, see if we can calm them down and see what's left. Recurrent disease, maybe I'll give you vancomycin ×1 for this recurrent episode. But if you come with me and you fail twice, you're done. You go right to transplant. And I've had tremendous success by using this, 95%. This is the future. I'm out of business. They don't like to call it the poop pill because they don't want the poop or the fecal part to be anywhere near this product. But this is where we're headed, and there are many different companies who are designing products. And actually, Series Health last week just had their product, Series 109, approved by the FDA for use in recurrent episodes of C. diff. And we'll be one of the first sites who will be using this in a clinical trial. JAMA just published an article. This was some of our colleagues up in Boston. Jenny Salk actually was a fellow here, and she was attending on staff here for a couple of years. They had 20 patients who had recurrent C. diff, and they were given this pill that they designed themselves, and they got a 70% primary cure rate. And if they gave them another 15 pills, it was 15 pills that they had to take, they had a 90% cure rate. So again, the upper GI route, maybe it's not as good as a lower GI route, but I'm sure that we can improve this by changing some of the technology. So what am I doing here at Mount Sinai? I'm looking at a specific cohort of patients, those with IBD, and seeing are there differences between the IBD cohort and the non-IBD cohort who have C. diff. I'm also looking very interested to see if we can use this product in IBD as a cure or something that we can improve their symptoms with. And this is a study that we're involved with, the FOCUS study. This is a group in Australia. Thomas Barodi, who's one of the leaders in the field, is part of this trial. The primary endpoint of this study is using fecal transplant to put patients in ulcerative colitis into remission. We have nothing to do with the clinical aspect of the study, but they're sending us all of the samples so that we can look at the microbiome, which is a big secondary endpoint for this trial. And then, of course, I'm looking at FMT and C. diff, and I will be part of the phase 3 Series 109 pill for recurrent C. diff. This is some of my initial data. So these are patients with C. diff. Once I give them a fecal transplant, and this is a marker of where their microbiome sits, what their microbiome is made of. After I give them a fecal transplant, they look remarkably close to the donor, and this lasts up to day 56. That's as far as we're studying right now. And we can see an increase in diversity. This is where they were before the transplant, and this is where they are after. This is normal levels of diversity. So what are the lessons from C. diff? We know that this is incredibly effective, greater than 90% cure rate. I would recommend considering FMT much earlier in the algorithm that we have now. And perhaps we should use this response-guided FMT. I think this is probably the best way. If you see pseudomembranes, you know that they're going to need another round of transplant. And then the question begs, why? What is it about the pseudomembranes that they just don't respond well? Is this a marker of severity, or is this something else? I think it's probably that if they have pseudomembranes, it's actually a membrane that's serving as a barrier for this good, healthy bacteria to latch onto. And so perhaps we just need to overwhelm them with another round. So what about other indications? Now, this is preliminary studies across the board. Some of it appears to be exciting, but hold back for a moment. Dysbiosis has been associated with many different diseases: multiple sclerosis, autism, fatty liver disease, obesity, atherosclerosis, diabetes, and of course, gut-related phenomenon: C. diff, IBD, irritable bowel syndrome. So what about obesity? This is a fascinating study that was done in mice a couple years ago, and Jeremiah Faith, who's now here with us, is one of the lead authors. They took human twins, one of which was lean, one of which was obese, and they gave their stool via transplant to mice. The mouse who received the obese twin's stool became obese. The lean mouse became lean. This is the part that I love. Mice are coprophagic. They eat each other's stuff, okay? When you house a mouse like this with a mouse like this, the obese mouse becomes thin. Amazing. I think we're onto something here, and my time here might be limited because I might have the cure for obesity. No. That has never been shown in human studies. I've been keeping accurate weight on my patients, seeing if I can do something, and no, there are no changes. But something that we should be potentially exploring in the future. This is what they actually found from their data. So this is the mouse who received the obese stool, gained weight. The lean mouse didn't, and when they co-housed the mouse, the obese mouse did not gain a significant amount of weight. This is just showing in a graphical form. What about diabetes? They took human stool from lean donors and gave it to men with metabolic syndrome. They gave them one fecal transplant, and then 6 weeks later, they looked at insulin sensitivity. This is before, this is after. Significant difference between the two. They also gave some men with metabolic syndrome their own stool. No changes were compared in that group. So potentially this is something that we could work on with diabetes. What about non-alcoholic steatohepatitis, Nash, fatty liver? If you look at patients with Nash, if you look at their microbiome, there are far fewer Bacteroides than there are in patients with healthy controls or patients with just simple steatosis, not related to fatty liver. What about IBD? So IBD is characterized by dysbiosis. What we don't know is this the cause or is this the effect? There's arguments depending on which person in the field you talk to for and against both of those reasons. This is from David Rubin up in Chicago, who's pooled all of the data we have to date on the use of fecal transplant in inflammatory bowel disease. 122 patients, and there was a 36.2% clinical remission for IBD, 22% for ulcerative colitis, 60% for Crohn's disease. That seems a little more than I would have expected, but this is the data that we have, suggesting further study. Well, further study has already taken place. This will be published in the July issue of Gastroenterology. These are 2 randomized controlled studies of fecal transplant and ulcerative colitis. This is performed from patients with mild to moderate UC. This is Paul Moyetti in the Canadian trial, and this is Rawson in the trial that was performed in the Netherlands. There were key differences between these 2 studies, mostly the donors. So for this study, it appeared that only 1 donor had sort of led to this effect, possibly. And this, they used 15 random donors. This was done via a nasoduodenal tube. This was done via enemas. So again, lower GI versus upper GI. And also the number of fecal transplants was different. They were given weekly enemas for 6 weeks, and these were only given 2 doses, one at time point 0 and one 3 weeks later. Clinical remission is what they were looking for, and the results show 24% for fecal transplant versus 5% controls, at least in the Moyetti trial. And in the Rawson trial, there was no statistical difference between the 2. Now, both of these trials were stopped by their data safety and monitoring boards because futility. This study, it's positive, but at the time of the interim analysis, it was negative. The Data Safety Monitoring Board allowed this study to include the patients who were already enrolled in the trial. 17 additional patients were enrolled. All of our, I think the majority of which received from donor B. Donor B cured 9 out of 17 patients and made this a positive study. Who is donor B? I'm going to find it. Now, it begs a question as to why was one positive, why was one negative? I think stool is heterogeneous. You know, when we screen donors, we're not looking to see who is a good donor. We're looking to see who is a safe donor. We don't know what makes up a good microbiome for certain disease processes. Possibly we need to use more. Maybe not. Maybe just overwhelm them with microbiota to get a difference. And possibly the mode of delivery. Maybe upper GI we shouldn't be doing. Maybe we should just be focusing on the lower GI route. So we're at the beginning of this microbiome explosion. We know that FMT is highly effective for C. diff. I have a 95% cure rate. FMT should clearly be considered earlier in the algorithm. And FMT is unlikely to have similar results in other disease states, other more complicated disease states. C. diff, we know what the problem is. It's C. diff. What's the problem with obesity? What's the problem with diabetes? What's the problem with inflammatory bowel disease? It's complicated. Maybe the microbiome plays a role, but there's other factors that we have to consider. And I'd like to thank the 2 people who have, or the 2 groups who have given me funding so I can do this research, the Success Grant, which is from an anonymous donor, and the Brill B. Crone Research Foundation for their support. Thank you very much.
Questions?
I noticed that the average age was 85, but the average age in your study was much lower, 50 something.
So I've done several pediatric patients, and those numbers are dominated by, I do a lot of IBD patients as well. And anybody with IBD is prone to be getting C. diff. So I see a lot of 20-year-olds, 30-year-olds, and so that brings my number down.
So what was the mean?
The mean is 65.
Okay, thank you.
The MIT company, does it pool the stool?
No. Each individual donor is tracked by themselves because they want to track outcomes. They want to see, is there a better donor, is there a worse donor, and who they should not be asking to donate any longer.
There have been many animal studies showing a very interesting interaction between gut microbiome and behavior and psychiatric manifestations. Has there been any attempt to do psychological follow-up of patients in a rigorous way?
So Tom Barodi in Australia is looking at everything and anything. He's actually looking at Parkinson's, which I thought would be pretty interesting. But no one, there may be a group in Mayo in Arizona that's looking specifically, I think actually looking at autism and not specifically behavioral issues, but it's possible.
Been anxiety and a very broad set of manifestations, again, in animal models with no humans to study, but
Yet.
obviously now.
There was a recent study in inflammatory bowel diseases in children, mainly because they were using pediatric hospitals. And they found that in this situation, there were decreased numbers of innate lymphoid cells in group 3, whatever that is. And they did studies that showed that decrease in the innate lymphocyte cells, group 3, allowed effector cells to create inflammatory situation in the bowel. So my question or suggestion, whichever it turns out to be, is that you might look in the C. difficile group and see if there was an increase in, if there's a decrease in the people with active inflammation, and see whether there's an increase in those who are successfully treated. What that would mean might be that we would now have a new drug costing $100,000 a year as opposed to a poop pill.
We are
But
big.
it's a question of pathophysiology.
I think it's a great point, because affecting the microbiome and giving this, whatever we're giving, it clearly is going to have effect on the immunology of the patient. And how that's actually being affected it's still unclear. There's been preliminary data suggesting maybe we're affecting T regulatory cells, which will have a major role in inflammatory bowel disease. But it just has not, we don't have any definitive data as of yet. But excellent point that the immunologic effect of fecal transplant is yet to be fully explored.
Harry, that was great. Thank you very much. I have 2 points. One is to thank you for making my life easier by curing my mother-in-law, whose anxiety is a lot better now. Secondly, there's data that shows that there's a difference between male and female microbiome. Is that why you see more females with C. diff?
Unclear. You're absolutely right, and during pregnancy, you see dramatic changes in the microbiome. It's interesting, if you look at a pregnant woman, her 3rd trimester, and you compare it to an obese female, they look equivalent. So there's this obese phenotype that we're saying. I wouldn't want to be. My wife is pregnant. Security. But we don't know, because again, we don't know what we're actually doing by doing a fecal transplant. There's all these theories, but we don't know what the effector part of this is.
Thank you very much. That's been fantastic. Really good. And you cured one of my patients too. I am stunned.